Good morning, my name is Angela Efram Horas with last digit number 055. So today, B10 will talk about asthma in child. So this is our member's name. We will start from chapter 1. So today I will explain about the background of the student project. Asthma is a chronic inflammatory condition affecting the air passages. This condition is distinguished by recurrent blockage of the air passages resulting from swelling, bronchospasm, and increased production of mucus. Individuals with asthma may encounter various symptoms, including wheezing, coughing, sneezing, difficulty in breathing, and sensation of tightness in the chest. Variation in the frequency and severity of symptoms are vary greatly. Severe asthma can cause respiratory failure and even death. CDC said over 6 million children in the United States are affected by asthma. There has been a notable increase ranging from 41% to 70% in instances where pediatric patients may school due to reduced lung function, emergency care visits, hospitalizations, and even fatalities. So it is so crucial to impact education on disease progression and effective asthma management for control. Maybe that's all from me. This presentation will continue by my friends. Thank you.
My name is Ananda Karaharja with last three digits of student ID numbers 136, and I will continue the problem formulations. So the number one is what is the definition and pathophysiology of asthma in child. Number two, what is the examination for asthma in child. Number three, what is the risk factor of asthma in child. Number four, how family interactions in child with asthma. Number five, how asthma impact the family. And the last one, what is the medical approach in prevention of asthma. And then the writing process is to answer the problem formulations, knowing about the definition and pathophysiology of asthma, knowing about the examination of asthma, knowing about the risk factor of asthma, knowing about the family interaction in child with asthma, knowing about the asthma impact in the family, and knowing about the medical approach and preventions of asthma. And the benefits of writing this paper for medical students and for the community is to enhance the understanding and knowledge about asthma in child. And also these contents intend to amplify the understanding of the definition and pathophysiology of asthma, the examination of asthma, the risk factor of asthma, the impact of asthma to the family, medical approach and prevention of asthma. And in addition, this student project is also expected to be a reference for other research related to asthma in child. Okay, maybe that's all from me. The next slide will be continued by my friend. Thank you.
My name is Anastasia Guidet-Rosling with my last three-digit student ID number 09. I'm going to explain about the definition of asthma in a child. Asthma can be defined as a persistent inflammatory condition affecting the airways, marked by recurring instances of airflow obstructions due to factors such as edema, bronchospasm, and heightened mucus production. Seasonal allergies, allergic rhinitis, and eczema or atopic dermatitis, collectively referred to as the atopic triad, are commonly linked with it. The recent Global Asthma Study, or GAN, phase reported that the global prevalence of asthma was 11% in children aged 6 until 7 years and 9.1% among children aged 13 until 14 years. Asthma has accounted for missed school days among children in Asia Pacific, about 16 until 61%. The next part will be explained by my friend.
My name is Anet Malinga. My last two digits with the number is 092. I will explain about the pathophysiology asthma in a child. Airway inflammation is caused by interaction with environmental and genetic factors, which include airflow and leads to functional and structural alteration in the airway in the form of bronchospasm, mucosal edema, and mucus plug. And there is four pathways that is the pathophysiology of asthma. The first one is role of inflammation. So chronic airway inflammation is associated with elevated PHR, leading to bronchospasm and characteristic symptom of wheezing, shortness of breath, and cough after exposure to origin, virus, cold air, or exercise. So this asthmatic airway inflammation may be caused by an imbalance between two opposing helper T cell recognition, TH1 and TH2. So TH2 is produced a cytokine that can mediate allergic inflammation. So, and then next one is the hypothesis of hygiene. So this is based on the idea that newborn immune system is geared toward the production of TH2 cytokine. Under this condition, the child's genetic background, including an imbalanced TH2 cytokine, set the state of synthesis of immunoglobulin A. Due to interaction between genes and culture and genes and environment, vulnerable hosts exposed to environmental stimuli that are capable of producing IgE and sensitization occurs. The next one is genetic factor. Several studies have focused on the role of genetic in asthma success susceptibility. There is a recently published meta-analysis of genome-wide Association studies of asthma in ethnically diverse population in North America identified 5 susceptibility loci. 4 of the loci have been previously reported at 17 key 21, and one of them is a novel asthma susceptibility locus at PAN1. An Australian study discovered 2 new asthma risk loci, RS412927 in IL6R and RS713588 on band 11T 13.5. So the IL6R association support the hypothesis that cytokine dysregulation affect asthma risk, that IL6R antagonists may therefore be beneficial. The result for the 11 key 13.5 locus suggests a link between allergic sensitization and the development of asthma. And the other factor is blood lipids that were related with asthma, airway obstruction, and bronchial reactivity and sensitization to airway allergens. This is suspected to causing asthma, but we don't know whether children with high LDL level are more likely to receive high dose of inhaled or systemic corticosteroid. But however, this is possible that these children exercise less, which may contribute to obesity and higher LDL. And there is a study that found a link between lack of lung function and bronchial responsiveness during infancy and the development of asthma by age 7. And there is a obesity that is suspected related to asthma. And then there is the increased risk of poor asthma control and obesity in children. And then there is a relationship between serum vitamin D level and patient IgE level, steroid requirement, and in vitro corticosteroid responsiveness. Parental smoking is associated with an increased risk of asthma. The risk of asthma is increased the more cigarette the mother smoke. That's all for me. Thank you.
Hello, my name is Alvaro with student ID number 200251113. I would like to continue the presentation about the examination of asthma in children. So before we start, the examination and the diagnosis of asthma is in children especially are often found to be quite challenging, resulting in many cases of either overdiagnosis or underdiagnosis of the asthma itself. To overcome that, overcome these issues, a series of complex examination according to the latest official guideline must be done properly. So the first one, of course, like any other disease that we can see in medic or health situation, is anamnesis. So we usually found like wheezing, dyspnea, and coughing are the 3 main symptoms that children with asthma usually exhibit. Moreover, asthma is particularly characterized by wheeze, and the child diagnosis of asthma is improbable of wheeze is absent. So non-asthmatic cough and wheeze, however, are very prevalent in the kids and can provide a diagnosis challenge to the physician. Regarding of that, the practitioner must not establish the diagnosis of asthma by history of wheezing alone. Furthermore, symptoms of asthma are found to occur episodically, and the amount of symptom recurrence become one of the bases in severity grading. Following the main symptom of other related symptoms also may occur, like sleep disturbance, fatigue, and chest tightness. So the patient with asthma in children have been frequently reported by their family members or relatives suffering from similar symptoms. Triggering factors also often highlighted. In the most cases, the most common trigger is viral respiratory infection, but are the several other recognition triggers as well, such as viral allergens, secondhand smoking, and variation of humidity or temperature of the surrounding air. The next explanation about the examination will be continued by my friend. Thank you.
So, thank you for the opportunity. My name is Amadis Mandalito, examiner with 3 last digit number 115, and I will continue the explanation about the examinations. So, for the physical examinations, physical examination should concentrate on 3 key areas, including general examination, all of the illness symptoms, and also respiratory dysfunction symptoms. Common respiratory exam findings in children with acute exacerbation of asthma include cough, extended expiratory phase, and wheezing, which can be either expiratory or inspiratory. And there also could be symptoms like grunting, increased labor of breathing, also known as belly breathing, tripod posture, nasal flaring, usage of auxiliary muscles such as subcostal, intercostal, or supraclavicular retractions, and an inability to speak in whole phrases. Although characteristics such as bird chest, reader, multicarial rash, localized wheeze, and digital clubbing may indicate comorbidities or other diagnoses. And next one is the supporting examination. So for children older than 5, lung function testing can actually help with the diagnosis of asthma. Spirometry and peak expiratory flow, or PEF, are frequently employed to evaluate airflow reversibility and blockage. And actually, Global Initiative for Asthma, or GINA, with their recent guidelines expressly suggest using spirometry or PEF combined with historical assessment and physical examination results for the diagnosis of asthma. But lung function assessment itself in children under 5 is seldom visible outside of research setting. This further complicates diagnosis in this age range. The lung function test itself will be performed twice, in which the first result will serve as baseline and the second test will be performed after the patients are given short-acting bronchodilator. And usually after the second test results will be lower in those with asthma. And also, phenol-tasting is also recommended as a means of identifying and measuring eosinophilic airway inflammation, but there are differences in global guidelines regarding the precise placement of phenol test. But when adjusting the dosage of ICS for those with a confirmed diagnosis of asthma, phenol monitoring may also be helpful. And lastly, while not often performed as a part of diagnostic process, RG testing, which includes skin prick testing or specific IgE level measurement, may be performed if necessary. And in fact, this test is advised by several guidelines and can help pinpoint particular triggers. That's all from me. Thanks all will be presented by my friend.
Greetings everyone, my name is Adi Vaibonapta Pratama, and I'm going to tell you about the risk factor of asthma in child. Asthma specific causation is still unknown. However, it appears to be impacted by a combination of hereditary and environmental factors. While a familial history reveals an increased susceptibility to asthma, it is considered unimportant and not sufficient for the development of asthma in children. Other risk factors as maternal smoking, child exposure to tobacco smoking, exposure to pet dander, dust mites, mold, and other allergens, as well as air pollutants, are all risk factors. Asthma is known to be triggered by viral respiratory tract infections. I think that's all from me. The next presentation will be continued by my friends. Thank you.
Hello everyone, my name is Angela Cynthia Carolyn. The last 3 digits of my student ID number is 068. Now I would like to tell you about family interaction in child with asthma. So family plays an important role in managing their children's asthma. A child's ability to cope with their asthma may depend on how well their family communicate, works together to solve specific issues and changes when there is asthma. In addition, parents must learn how to monitor symptoms, take prompt action in response to changes in the condition, and comprehend the many asthma medications in order to effectively manage their child's asthma in order to support their children. That's all from me. The next slide will be presented by my friend. Thank you.
Hello, my name is Amanda Raisa Suryananda with a student number of 2002-511-237. So continuing the presentation with the impacts in the families, one of the impacts is families often fear and worry when their child has asthma attack. So it can make emotional distress to their families. Also, there are some of lifestyle adjustment, such as reducing smoking to not trigger the asthma. It is also can make financial difficulties as for the medical expenses needed. Families also have lack of sleep because the attack of asthma usually occurs in midnight, and siblings also can be feel neglected due to the parents' attention is more focused on the sick child. That's all from me. The next presentation will be continued by my friend. Thank you.
Good afternoon. My name is Alexandra Cahya Putri with my 3 digits number 112. Today I'll be presenting regarding the family medicine approach of asthma in children. So the role of family medicine is incredibly significant because the prevalence of asthma in global level is increasing, and also asthma itself requires lifelong treatment, and therefore it is very important that family physicians build an efficient partnership with patient and also their caregivers. And the family medicine approach is divided into 3, which is the comprehensive approach, the collaborative approach, and also the continuing care approach. Today I'll be explaining about the comprehensive approach. So it is very imperative that
the goal of comprehensive approach itself is to achieve adequate symptom control and reduce forthcoming risks of asthma exacerbation. This is done through several steps. The first one is diagnosis and treatment, and then treatment and management, and then lastly, regarding patient and caregiver education. So the diagnosis of asthma, the first one, is done by a combination of identifying clinical symptoms such as wheezing, and then identifying family history, atopy history, and then whether there are triggers, and as well a combination with physical examination. Also, during diagnosis, family physicians can also conduct investigations such as spirometry, and then also assess the severity of asthma by the frequency of episodes, and also nighttime awakenings. And then for treatment and management, the second one usually given a reliever and a controller. And then third one is patient and caregiver education. In terms of comprehensive approach, family physicians should really educate on a lot of aspects. The first one regarding the patient's preferences on using the inhaler, its capability on using inhaler, and also the adverse effect, the medication expenses. And then it's important that family physicians also educate patient and caregivers regarding the disease chronic nature and the importance of adhering to treatment, and then identification of specific triggers, and discuss regarding how to modify the environment for the child itself so that it can we can control the asthma exacerbation that is caused by the environment.
Hello, my name is Almanda Chandra with 3-digit student ID number 086, and today I will explain about the collaborative approach and continuing care approach. Collaboration is crucial in asthma management, involving patients, caregivers, healthcare professionals, and various stakeholders. Teamwork among the pediatrician, allergy specialists, and other experts is essential. Family physicians should also coordinate with schools, daycare centers, and coaches to prevent asthma exacerbation. In family medicine, building a long-term partnerships with caregivers is vital. Clinicians must ensure caregivers have necessary knowledge for managing asthma in children, such as emphasizing adherence, medication usage, inhaler techniques, recognizing symptoms, and formulating action plans. That's all. Thank you.
Hello, my name is Ananda, and I'm going to continue the presentations. So the preventions of asthma in child, the family medicine approach, there are three preventions. First is the primary preventions, which consists of reducing the risk factors exposures, such as allergens, including low birth weight, pet keeping, exposure to cockroaches, physical environments, and sedentary lifestyle. Secondary prevention is based on several tests, such as skin patch tests, that needs to be socialized to a family in order to achieve early care and treatment. Study shows delays in diagnosis for asthma will delay treatments and shows worse quality of life. Whether the types are preventions, this goes for the patients or asthma in child is already suffers asthma, where it is needs for patients to reduce known allergen exposures to their child. Parents should know about asthma symptoms and reminding their child to take medications accordingly. There is also evidence that asthma severity depends on oxygen saturations and nebulizing frequency.
Hello, my name is Kosalia Arini, and I'm going to continue the presentation part of this paper, which is the conclusion. So asthma affects around 6 million US children, primarily T2 and type 1 asthma, linked to allergy resistance or even genetic and environmental factors, including hygiene hypothesis, contribute to its development as well. Effective management in elementary school with collaborative family efforts is crucial for optimal symptoms control and reducing future exacerbation risks. And that's all from me. Thank you.